This is Juan Marayo, Dr. Juan Marayo. I'm going to be talking today about transfusion reactions. This is the module 17 in the PBT program. I hope this information is useful. First, reminding you that the readings that are mandatory include the Howard Chapter 11 regarding adverse transfusion complications, media lab course for transfusion reactions. There are some optional readings as well in the ABB technical manual, as well as the Harmony book. First, I'm going to talk about the FDA fatality report. This is posted by the FDA website to contribute on giving data on the transfusion-related fatalities and donation also related fatalities. The annual reports align with the case definitions and imputability criteria used by the Centers for Disease Control and Prevention, the CDC, also the National Healthcare Safety Network. You can have the link there. The International Society of Blood Transfusion, ISDT, in collaboration with the International Hemovigilance Network and the ABB Donor Hemovigilance Working Group, as well as the British Serious Hazards of Transfusion, or SHOT, and the Hemovigilance Activity Report of the French National Agency for the Medicines and Health Public Safety. When we look at the definitions in the CDC, an adverse event is an unintended and undesirable occurrence before, during, or after transfusion of blood or blood components. Adverse events include both incidents and adverse reactions. So adverse reaction is defined as an undesirable response or effect in a patient temporarily associated with the administration of blood or blood components. It may or may not result in an incident. Now, an incident is any error or accident that could affect the quality or efficacy of blood components for patient transfusions. It may or may not result in an adverse reaction in a transfusion recipient. Finally, a near miss is a subset of incidents that are discovered before the start of a transfusion that could have led to a wrongful transfusion or an adverse reaction in a transfusion recipient. Let's keep these definitions in mind. ABB hemovigilance for patient safety contains resources for that matching the CDC hemovigilance module, including definition of definitive, probable, or possible for the diagnosis in question. A recent update on the ABB letters include that it's called now the Association for the Advancement of Blood and Biotherapies. Association for the Advancement of Blood and Biotherapies. And it's been 75 years since their foundation. Several names have changed. It used to be the American Association of Blood Banks. Now it's called Association for the Advancement of Blood and Biotherapies. How safe is blood? Is a blood transfusion? And the answer to this question depends on the time of the human evolution that you ask about. Currently, transfusion is considered a death risk, according to the FDA reports. I combined in groups of 5 years. So I started with 2005 to 2009, and in that period, 252 deaths related to blood transfusion were attributed. Between 2010 and 2014, it went down to 176, including one donor. And between 2015 and 2019, the latest reports is still about close to 200 and 192. Looking at transfusions per year, worldwide, there are about 100 million red blood cell transfused. In the United States, about 13 million red blood cell units, and that number varies every year. And it's apparently plateauing around 12 to 30 million now. And we look at every blood component transfused in the United States, about 30 million, as I said, in the United States. And that was published in the Annals of Internal Medicine in 2012. This graphic shows a comparison between transfusion risks compared with the normal risk for fatality in a person per year in various life events. When we look at the most common ones, you have fever and transfusion-associated circulatory overload, as well as allergic reactions, which is not mentioned here. So these are going to be 1 in 100. And we'll hear more about some of these reactions, especially TACO, later in the presentation. The next group will be 1 in 10,000, and that includes TRALI, the transfusion-related acute lung injury, and it's comparable with fatalities in motor vehicle accidents or falls. Finally, I'm going to look into the 1 in 1 million, which includes what people are sometimes more worried about, the hepatitis and HIV. It's going to be similar to the fatal risk, fatal hemolysis risk. And when you look at normal daily life, airplane fatalities and lightning fatalities will be comparable. And if you're not worried about those two, then you shouldn't be worried about the others. The vast majority of adverse events in transfusion are non-fatal. It's important to keep that in mind. When you look at the different risks and events per unit transfused, when you look at fever, chills, non-hemolytic in red blood cells, it will be 1 in 200 units. When you look at the platelets, it's going to be 1 in 100 platelets. If they happen to be non-leukocytes, then it goes way high in 1 in 50 units. Looking at urticarial, it's about 1 in 250 units. The blood supply is safer today than any time in history due to advance in donor screening, looking at the medical history, improved vital marker tests with new generations, automatic data systems, including the questionnaires, and changes in transfusion medicine practice with the patient blood management and better training on the new generation of healthcare providers. Current methodologies cannot eliminate all potential risks associated with blood transfusion. The risk for an error with resulting harm is about 1 in 4,500. So that risk is going to be there. On this table from the AABB guidelines published in JAMA 2016 shows an approximate risk per unit transfusion of red blood cells and the adverse events on the left. So this just mirrors what we just discussed. Talking about residual risk and infectious window period for hepatitis and HIV, we can see that the window period is largest for hepatitis B, which makes it highest residual risk per donated unit from 1 in 850 to 1 to 1.2 million. When we look at the hepatitis C, for example, the window period is the shortest, about a week, and the residual risk is about 1 in 1.1 million. If you look at HIV, window period is about 10 days, then the residual risk is considered to be 1 in about 1.5 million. And this is published in the 20th edition of the technical manual. Now we're going to concentrate on a few common transfusion reactions. First, let's define how you classify transfusion reactions, and one way is to define it as acute or delayed. The acute one is going to be less than 24 hours, and delayed is going to be over 24 hours. And these are some of the acute transfusion reactions that can happen. Includes hemolytic, febrile non-hemolytic, bacterial contamination that can lead to septic shock, allergic, anaphylactoid or anaphylaxis, transfusion-related acute lung injury, and transfusion-associated circulatory overload. This table is from the AABB technical manual that will have the type of reaction, and in this case, we're talking about acute, less than 24 hours, and another type of classification is immunologic or non-immunologic. In this case, these are going to be immunologic. We will see here the incidence, etiology, presentation, diagnostic testing that can be performed, and therapeutic or prophylactic approach that can be used to prevent or treat these reactions. I'm going to be presenting a little more about hemolytic later on, but here you can see in general that ABO-RH mismatch is 1 in 40,000, the incidence. Acute hemolytic transfusion reaction is 1 in 76,000, and the fatal hemolytic reaction is about 1 in 1 to 2 million, basically. The etiology is red cell incompatibility, and the presentation will have fever, chills, hemoglobinuria, hypotension, renal failure with oliguria, uh, disseminated intravascular coagulation that can be shown clinically as oozing from the IV sites, back pain, pain along the infusion vein, and anxiety. For the testing, we need to do the clinical check, DAT, visual inspection to look for free hemoglobin or hemolysis. Repeat the patient ABO in the pre and the post transfusion samples. Further test as indicated to define the possible compatibility, and further test as indicated to detect hemolysis like LDH or bilirubin. For therapy, keep the urine output about 1 milliliter per kilo per hour, and diuretics can be used to help. Analgesics for the pain and pressors for hypotension, and also some components may be needed like platelets and cry or FFP if the patient starts bleeding. Another common one is the febrile non-hemolytic. That could be from 0.1 to 1% of after universal leukocyte reduction. The cause is because of accumulation of cytokines in platelet units or antibody to donor white blood cells. They present with fever and chills or rigors, headache and vomiting. And to do rule out hemolysis, we do DAT, inspect for hemoglobinemia, repeat the patient EVO, rule out bacterial contamination as well, since that could be one of the symptoms, and look at the white blood cell antibody screen as needed. So to prevent it, the leukocyte review components are helpful. Also using antipyretic pre-medication, like I said, aminofen, aspirin is not recommended since it blocks platelet functions. Continuing with acute transfusion reactions, immunologic type, anaphylactic reaction is about 1 in 20,000 to 1 in 50,000. And the etiology is antibody to donor plasma proteins that may include IgA, haptoglobin, or complement, as well as cytokines. The presentation is hypotension, urticaria, bronchospasm with respiratory distress and wheezing, local edema, and anxiety. For diagnostic, we can rule out hemolysis with DAT, inspect for hemoglobinemia, and repeat the patient ABO. Look for the antibodies against IgA, and also to quantify IgA levels. For therapeutic procedures, we elevate the patient's leg with Trendelenburg, put some fluids, epinephrine, antihistamines, corticosteroids, and IgA deficient blood components if the patient actually have the anti-IgA antibodies may help. Looking at transfusion-related acute lung injury or TRALI is one of the major killers. And the incidence is about 1 in 1,200 to 1 in 200,000. The etiology will be, one of the theories is that this white blood cell antibodies in the donor, and occasionally it can be in the recipient, or other white blood cell activating agents in the components. The presentation will be hypoxemia, respiratory failure, hypotension, fever, bilateral pulmonary edema, and some testing that can be performed and need to be performed include rule out hemolysis, rule out cardiogenic pulmonary edema, which again will be a different diagnosis in that case, considered to be transfusion-associated circulatory overload or TACO. White blood cell antibody screen in donor and recipient with positive antigen typing may be indicated, white blood cell cross-match, and chest x-rays. Sadly, there is no actual good therapy for this, just supportive care until recovery and defer implicated donors. And the supportive care may include oxygen therapies for the deferral of the donors. If you find a donor that can be attributed to the cause of this reaction, then that donor may need to be deferred. The transfusion-associated circulatory overload, or TACO, we can see the incidence is close to 1%. The etiology is volume overload, and the patient will have similar symptoms than Australia, dyspnea, orthopnea, cough, cyanosis, tachycardia. But then in this case, you will have hypertension, which is rare in a transfusion reaction. So hypertension would be a telltale that this may be a PACO. Headache. For diagnostic, you can use the chest X-rays. You will see the pulmonary edema, and always rule out TRALI. For therapeutic, keep the upright posture, oxygen, IV diuretics, and phlebotomy may be indicated in some cases to decrease the volume overload. Looking into delayed transfusion reactions, we have the hemolytic as well, transfusion-associated graft-versus-host disease, which is rarely seen these days, platelet refractoriness due to aluminization, post-transfusion purpura, transfusion-transmitted infections, which is also rare lately, except for one of them that you will see in the following slides, and iron overload, which can be seen in patients with multiple transfusion, chronic transfusions like sickle cell or thalassemia, for example. For the delayed, more than 24 hours transfusion reactions, immunologic types, we have this in the table from AABB. And in the bottom here, you can see delayed transfusion reactions, non-immunologic, which includes iron overload. For aluminization, you can have red blood cell due to red blood cell antigens, that's about 1%. It's an immune response to foreign antigens on red cells. They present with positive blood group antibody screen test. And the diagnostic test, of course, is going to be the antibody screen and the DAT. And therapeutic prophylactic approach will be to avoid unnecessary transfusions and give leukocyte-reduced components to prevent these kind of reactions. With aluminization, due to HLA antigens, that's about 10%, 1 in 10 is the incidence. Is due to white blood cells and platelets with the HLA antigens. Presentation will be a platelet refractoriness. That means that the patient does not get the appropriate response when you transfuse platelets, and delayed hemolytic reactions and hemolytic disease of the fetus and newborn can be some of the presentations. Diagnostic testing, platelet antibody screen, and lymphocytotoxicity test, if available. The therapeutic approaches include avoid unnecessary transfusions and give leukocyte-reduced components as well. Other important reactions I'm going to talk about later is going to be hemolytic reactions. And also I want to mention here the graft-versus-host disease is a rare condition nowadays, since the prevention will be to do irradiation of blood components for patient at risk, including related donor and HLA selected components. So any kind of cross-match like HLA match or cross-match compatible platelets need to be either irradiated or pathogen-reduced components, which will be preventing the white blood cell from replicating and having this type of reaction, which is fatal in the vast majority of cases, above 90%. And the post-transfusion purpura is also rare. It's mostly due to recipient platelet antibodies, usually with anti-HPA1 that actually destroys the autologous platelets. So the reaction will destroy its own platelets. They have thrombocytopenia, bleeding 8 to 10 days after transfusion. And platelet antibody screen can help identify this. And the therapy include IVIG, HPA1 negative platelets, if that's the antibody, and plasma exchanges in some cases. So far, I don't have any case that we have done that plasma exchange yet. We'll continue with the next slide. Talking about delayed hemolytic reactions, the incidence is 1 in 2,500 to 11,000. The etiology is red cell destruction from the combination of significant hemolytic antibody and antigen specificity to large number of transfused red cells. Antibody coats the red cell transfused, resulting in extravascular hemolysis. Antibody positive part of the red cell membrane removed in the spleen and liver mainly. Of course, also can happen in wherever you have macrophages, including the bone marrow. And the management is supportive care, giving fluids, diuretics as needed, but especially antigen negative components if transfusion is needed. That would be the best therapy. Looking into these images, you can see here labeled red blood cells in this electron microscopy scanning, and the M is for macrophage. So this is another red blood cell here being engulfed by the macrophage, trying to again swallow and destroy those attached antibodies. This is another way to see it. This is the red cell and the macrophages around it. Red blood cell antibody persistence. It's important to keep this in mind since antibodies may disappear in time. And in a retrospective review here from shown from 1978 to 1997, 480 patients with 593 antibodies, 26% of the antibodies became undetectable over the course of time in months. So that means that's why it's so important to have the clinical history of previous transfusions and any kind of antibody identified before in order to release the safest components in red cell transfusion. Bacterial contamination reaction. The incidence is 1 in 5,000 to 1 in 500,000, depending on the product type. The more common ones are going to be probably platelets, and the least common in plasma products. Is number one infectious risk from transfusion? It's actually bacterial. The organisms that can be seen in red blood cells due to asymptomatic bacteremia and blood collection can be Yersinia, Citrobacter, E. coli, Pseudomonas. If it's a platelet product, it's due to contamination at blood collection usually. And in those cases, you will see gram-positive cocci, staph, or strep, for example. The bacterial contamination reaction signs or symptoms include rapid onset of high fever. If it's a very fast reaction, most likely it's going to be a gram-negative that already had the cytotoxin release or the endotoxin release in the product. If it's over an hour, it's usually gram-positive. You can see patient may develop rigors, abdominal cramping, nausea, vomiting, and shock. Case reports of septic shock related to contaminated autologous units have been described. So autologous units will not prevent this. And reported mortality rate is up to a quarter of the patients will die. So pretty high, especially in the gram-negative contamination. The bacterial contamination reaction, the severity is related to number of bacteria present at transfusion, initial inoculum size, bacterial growth characteristics, that depends on the ambient temperature, volume of the component storage time as well, recipient immune status, if they're immunosuppressed, then that's not good, and concomitant antibiotic administration may help. Most clinically significant septic transfusion reactions occur with red blood cells that are stored over 21 days and platelets if they're stored over 3 days. The treatment will be immediate IV antibiotics, blood pressure support. The prevention will be careful donor history, proper phlebotomy technique, and careful monitoring of blood product temperature during the storage and transport times, and also platelet surveillance, including the bacterial testing that is being performed before releasing the product. Looking into acute hemolytic reactions, the incidence is 1 in 76,000, occurs within 4 hours of transfusion, most likely, results from the reaction of the preformed antibodies, usually ABO antibodies, with transfused red cells. Antibody causes the transfused red cells, activates the complement system, and results in intravascular hemolysis. The mortality could be up to 40% and above, depending on the amount of incompatible blood transfused in many cases. Here is a microelectronic photograph. This is the inside of the red cell, this is the membrane, and this is the outside of the red cell. You can see here rupture of the membrane due to the complement. Mortality versus incompatible blood amounts, looking into some research done, a review of 41 hemolytic transfusion reactions causing renal failure, no death if less than 500 mL of incompatible blood was transfused, 25% mortality between 500 and 1 liter, and 44% if it's more than 1 liter of blood, incompatible blood. At least 12 of the 158 deaths reported to FDA involving but less than 1 unit, as little as 30 mLs actually has been reported to cause death. This was reported in this publication from ABB in 2001. The signs and symptoms of hemolysis may vary depending if it's intravascular or extravascular. In intravascular, both of them will, the first one is a fever and or chills, 82% intravascular, 50% extravascular. The second one will be also for both renal failure with higher prevalence in the intravascular patients with hemolysis. Pain, and you can see the other percentages lower. If you compare dyspnea and disseminated intravascular coagulation, it's about 10 times more frequent intravascular compared with extravascular. The management of these acute reactions is first to stop the transfusion. Then you initiate the transfusion workup, notifying the blood bank, fill out the transfusion reaction form, send repeat blood samples and urine specimen as needed, provide appropriate supportive care, and most importantly, do not restart the unit until it's clarified. One of the last things I want to remember, is that other transfusion is also a risk in transfusion, and it's important to educate again the clinicians to appropriately use the blood components as needed. In conclusion, over the last 30 years, blood products have become relatively safe from an infectious disease standpoint. Unfortunately, blood transfusions are not risk-free. Missed transfusions and transfusion reactions must be considered when deciding to initiate a blood transfusion. These are some references that you can use to further read about this topic. And I thank you for your time. And I also put a link here in the blood typing game that you can practice online in the nobelprize.org website. Thank you very much.